Hello everyone, I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today, this is a very important topic, thromboembolic disorders in pregnancy. It is very important. It is a life-threatening condition that may happen during pregnancy or in the weeks postpartum. So, let us discuss this important topic. What are the objectives? The pathophysiology, thromboembolic complications, the risk factors, the epidemiology, how to diagnose and how to treat such condition. Okay, about the pathophysiology, during pregnancy, there is hypercoagulable state, there is venous stasis, and also there is possibility of injury, venous injury, which may happen during delivery. Okay, so this is called the VKA triad. This make pregnancy is a risk factor for thromboembolism. But you should know that the most dangerous time is the postpartum one, with limited mobility, especially those who did cesarean section or those with instrumental delivery. So postpartum period is the most dangerous. So most thromboemboli develop postpartum and result from vascular trauma during delivery. Okay, what are the risk factors? Severe inherited thrombophilia, also presence of antiphospholipid antibody. Other risk factors like multiparity, body mass index more than 30, age older than 35, immobility, ART, varicose vein, paraplegia, sickle cell disease, heart disease, nephrotic syndrome, systemic lupus, inflammatory bowel disease, and of course, superior venous thromboembolism. What about the epidemiology? Women who are pregnant or in the postpartum period have fourfold to fivefold increased risk for thromboembolism compared with non-pregnant women. So imagine how big is the problem. Fourfold or fivefold increased risk of thromboembolism during pregnancy compared to non-pregnant women. And the risk of venous thromboembolism is estimated at 5 to 12 per 100,000 pregnancies and postpartum compared with age-matched non-pregnant women. And the risk of venous thromboembolism is highest in the first 6 weeks postpartum. And you should know that venous thromboembolism is responsible for 3% of all maternal deaths worldwide and 9% in the United States. So, venous thromboembolism is a leading cause of maternal deaths in the United States. Okay, what about the diagnosis? Complete history taking and physical examination and do some imaging and lab investigations. Okay, what about symptoms and signs in pregnancy? Include shortness of breath, which is the commonest symptom, constitutes 34.7%. Shortness of breath. followed by tachycardia, constitutes 30.4%, followed by chest pain, 13% of cases, and leg pain or weakness in 9% of cases. Okay, this is the symptoms and signs of venous thromboembolism. There may be symptoms of thrombophlebitis like warmness, tenderness in the leg, edema, redness, okay, but may be absent also. Okay, so it is very important to know that thromboembolic disorder can occur without symptoms, or with only minimal symptoms, or with significant symptoms or severe symptoms. Even the cough, edema, cramping, and tenderness may occur normally during pregnancy and may simulate human sign, which is one of the signs of DVT. Okay? So, thromboembolism may happen without evident physical sign in the legs. There is no evident DVT. You can detect it on physical general examination. Okay? May happen due to pelvic thrombosis, iliac vein thrombosis, ovarian vein thrombosis, and so on. What is the investigation? Doppler ultrasonography, or sometimes CT with contrast, for diagnosis of deep venous thrombosis. In the postpartum period, if Doppler ultrasonography and plethysmography are normal, but you are suspecting iliac, ovarian, or other pelvic venous thrombosis, so please go to CT with contrast to diagnose this pelvic venous thrombosis. Okay? Okay. Helical CT or spiral CT for pulmonary embolism is important, and diagnosis of pulmonary embolism is increasingly being made by helical CT rather than ventilation perfusion scanning, because CT involves less radiation and is equally sensitive. So both of them can diagnose pulmonary embolism. Ventilation perfusion scanning and CT, helical CT, okay, or spiral CT. But spiral CT is associated with less radiation than ventilation perfusion scanning, and again gives the same result as regard the sensitivity in diagnosis of pulmonary embolism. So use CT, we advise use CT rather than ventilation perfusion scanning. Okay, the helical one or spiral CT. But if still pulmonary embolism diagnosis is uncertain, pulmonary angiography is required. Okay, what about lab tests? Some tests can be done like D-dimer, brain natriuretic peptide, and troponin. Let us go to treatment for women with increased risk, especially those with 3 or more risk factors. Prophylactic low molecular weight heparin like enoxaparin, 40 mg subcutaneous once per day. In the market, maybe like Lexan, 40 mg, and so on. Or unfractionated heparin, 5,000 units subcutaneous every 12 hours throughout pregnancy and for 6 weeks postpartum. So, using anticoagulant if the patient carry risk factors, 3 or more risk factors, please start once pregnancy diagnosed, start to give the patient low molecular weight heparin, for example, enoxaparin 40 mg subcutaneous once a day. Or if it is not available or expensive for the patient, you can give unfractionated heparin 5000 milligrams subcutaneous every 12 hours throughout pregnancy and for 6 weeks postpartum. Okay? What about if the patient hemodynamically stable but acute case? Okay? You should give anticoagulant as a first line treatment. You have the two types of heparin, low molecular weight heparin and the unfractionated heparin, and both of them safe in pregnancy. They don't cross the placental barrier. They cannot reach the baby. Okay? So both of them can be used. However, low molecular weight is the anticoagulant of choice for antenatal venous thromboembolism. Why? Due to its better bioavailability, low risk of bleeding, low rate of heparin-induced thrombocytopenia and osteopenia. And the standard dose of enoxaparin is 1 milligram per kilogram subcutaneous injection every 12 hours. How to do monitoring? Perform anti-factor 10 weekly for 3 weeks at initiation, then once per trimester. Okay, this is as regard low molecular weight heparin. What about unfractionated heparin? Is it still used in pregnancy? Yes, it is still used in pregnancy, sometimes because low molecular weight heparin is not available or because of the higher cost of low molecular weight heparin. So still has a role in use during pregnancy, unfractionated heparin. Also, it has an advantage as regard it is the preferred method in cases of renal dysfunction, and also it is used intravenous in patients with a high burden of thrombosis, possibly requiring thrombolysis. Also, it carries the advantage it can be used around labor and the delivery or an anticipated procedure. Why? Because it has a short half-life and is readily reversible. Okay, this is an advantage of unfractionated heparin being has short half-life. So if I'm in emergency around labor, so it is more suitable and is readily reversible. Okay, unfractionated heparin can be given as a continuous intravenous infusion or subcutaneous dose every 12 hours. Dosing should be monitored with heparin level and the activated partial thromboplastin time levels. However, the activated partial thromboplastin time level is less reliable. Okay? It is recommended that therapy be extended for at least 6 weeks postpartum, as I said before. Let us go to another method of anticoagulant, which is oral anticoagulant, Warfarin, oral vitamin K agonist. Can I use Warfarin during pregnancy? No, it is not preferred as it crosses the placenta and can be teratogenic and cause embryopathy and many congenital malformations. The risk of congenital abnormalities with warfarin is 3.7% to 6.4%. So it is better to give low molecular weight heparin or unfractionated heparin as an anticoagulant rather than to give warfarin to avoid this fetal complication and this congenital malformations. Okay? In the postpartum period, warfarin has been detected in breast milk in tiny amounts, but is generally considered safe to use while breastfeeding. So you can shift from injection with low molecular weight heparin or unfractionated heparin to oral warfarin in the postpartum period during breastfeeding to achieve the maximum anticoagulant effect. So we may need to be bridged from heparin to warfarin to decrease the risk of recurrent venous thromboembolism, because warfarin is highly efficient. But the problem, I can't give it during pregnancy because of the congenital malformations that may happen due to its use, because it passes through the placental, through the placental barrier, okay, to the fetus. But during postpartum period, you can bridge from heparin to warfarin and continue the anticoagulant therapy, okay? What about the new drugs, new anticoagulant, like the direct oral anticoagulant, newer non-vitamin K oral anticoagulant that directly inhibit clotting factors? Their use become widespread in non-pregnant population. Why non-pregnant? Because there is risk during pregnancy. Case reports and cohorts of pregnant women exposed to direct oral anticoagulant in pregnancy show an elevated risk of congenital anomalies and increased maternal bleeding. So there is two problems with this new drug, the direct oral anticoagulant. It causes congenital anomalies for the fetus and also increase maternal bleeding. So it should be avoided throughout pregnancy or in women trying to conceive. What about thrombolytic agent? Can I use thrombolytic agent like tissue plasminogen activator, for example, which appears to be the best thrombolytic agent? Yes, I can do it. Pregnant women who are hemodynamically unstable or severely hypoxemic should be treated with thrombolysis if there are no contraindication, because it is life-saving here. So, a woman hemodynamically unstable, severe hypoxemic, I can give thrombolysis like tissue plasminogen activator. There are case reports of the administration of thrombolytics to pregnant patients with no resulting complication to the mother or the newborn, but there is many running studies. We are waiting for the results to be sure of its safety. What about surgical thrombectomy? Excision of this thrombus via surgery. Surgical thrombectomy is another alternative to systemic thrombolysis and also may be considered when thrombolytic therapy has failed. Okay, so it could be an alternative to systemic thrombolysis or may be considered when thrombolytic therapy has failed. Limited data suggests that although maternal survival may be high after surgical thrombectomy, fetal death rates can be elevated. What about temporary intravenous filters? This temporary intravenous filter have also been successfully used in pregnancy in cases in which anticoagulation is contraindicated or to manage the risk of clot recurrence around labor and delivery. Usually the use of temporary intravenous filter to prevent recurrence of thrombosis. Okay? Also when anticoagulation is contraindicated. A systematic review has found no fatal pulmonary embolisms in women with inferior vena cava filter placed along with no recorded fetal morbidity or mortality. So, in systematic review, there is a good result that mentioning no fatal pulmonary embolism in women with inferior vena cava filters placed along with no recorded fetal morbidity or mortality. This is as regard the temporary intravenous filter if indicated. This is the end of my lecture. Please remember my books published in Amazon: Textbook of Obstetrics, Textbook of Gynecology, Contraception Handbook, and the Multiple Choice Question. And this is my site on Amazon as a author, and this is my site on YouTube channel where you can find many other lectures, and my other scientific site on Blogspot. By the way, I have another lecture related to thromboembolic disorder with pregnancy, but just for risk assessment. Okay, risk assessment scoring. You can find it easily on my YouTube channel. Thank you, everybody.